Oh, this system. I apologize to everyone who's on. I have no idea what happened, why all of a sudden the other meeting just stopped. I hope everybody logs back on. I hope everybody's logging back on. I don't know what happened, why the other meeting abruptly stopped. Let's see if we can get Dr. Morgan back on.
Yeah, they're working on getting him back on. We've
Okay.
overcome worse tragedies and prevailed, so not to worry.
For those of you logging back on, our meeting suddenly ended. I do not know why. And we're trying to get Dr. Morgan back on and the meeting back up.
He didn't know that it had gone off, so he was talking.
Okay,
So he's trying to log back in now.
thank you so much.
Okay.
Technology is wonderful, isn't it?
When it works.
When it works. Dr. Randall is back on.
Well, hello.
Hello?
I'm back, I think. I'm gonna
I
have to
think
go.
you are back. I'm going to again make you a co-host. I do not know what happened.
I don't either, but I mean, it may well be my
So if you want to share
uh
your screen again, you
yeah.
can. We're talking about some statistics when
No,
everything.
oh, is that when it went? Okay, I'm
Yes.
gonna try my best to okay.
When you share your screen again, I'll kind of help you know where we heard the last, okay?
Okay.
You're on the AAMC slide.
Right.
Brent.
Okay, and share.
So scroll down. Yeah, keep going. Keep going. Okay, that's
I think I was on that one, wasn't I? Or
Yeah.
well, it was a couple before, but this will be good.
yeah, well,
That
Yeah,
one.
that's the slide you were on right there.
all right. So is everybody with me?
I think so. There are a couple of people who haven't logged on, but we have quite a few on.
Okay, well, thank you. And I'm sorry about those technical issues, but I guess that's part of being a physician. You just roll with it. And then I'm going to kind of try to move a little bit more rapidly here so that we still have some time for questions. Let me see where we are. So I probably have about 10 minutes to present, 10 to 12 minutes, and then we'll finish with questions. So I think this particular slide, I was just indicating that uh, African-American females are 5,217 with the enrollees this in 2023, 2024, as opposed to males at 3,011. And there are a number of very interesting factors if you look at the statistics more closely, and that is that there are many applicants who self-identify both as Black and identify as mixed race. And so I'm wondering how that really affects the true numbers. Then there's the whole issue of the domestic um, uh, Black versus those who are immigrants from Africa and the like. But in essence, what we're seeing is that there's a flat line or a slight decrease of males entering medical school and a continuing increase in females. And there's been some difference with African American applications over the past 10 years, maybe about 5% increase, which is positive, but we're still very far behind. We know racism and other isms are alive and well, and we're now being challenged in a very non-supportive way. This is ultimately the challenge to our individual right to good health care, because now we're kind of wondering who has the right to have health care with all of the challenges that we have. I saw the latest challenge to DEI and the whole matter of medicine and health that is being put before Congress now. So I think we all need to come up with strategies that are going to help us here. Now there have been a number of important programs and papers in medicine that have led to where we are in terms of even the Affordable Care Act, and led to the foundation or forming of the Cobb Institute. So just very briefly, in 1986, there was the Heckler Report, which was commissioned by Congress in 1985 to actually look and define what is occurring in health in the United States at that time. And the fact was that African Americans had a shorter lifespan, and there were far too many unnecessary deaths in the United States each year. That was raised to a new level of national awareness. And the reality is that we continue to have these unnecessary deaths. And that's why all of us who are very concerned about health disparities understand the true consequence of health disparities and health inequities. Following that, in 2002, just shortly before we moved to Florida, and I became introduced to the Cobb Institute, the National Medical Association had been working on all these different clinical areas of disparity among our patients, and pushed to have a study that really helped to understand why certain patients did not do as well as other patients that were afflicted with these conditions. And so unequal treatment was the document that the Institute of Medicine published with some contribution of members of the National Medical Association and others. But of interest, there was some discussion only of pediatric disparities related to injury. And there were many other disparities that were not even mentioned at the time. But it was important to understand that the sources of these disparities are complex. They're rooted in historical and contemporary inequities, and involve many participants at several levels, including the health systems and both the administrative and bureaucratic process of utilization managers, healthcare professionals, and patients. That's a lot of word salad, but the reality is, fast forward 22 years, and we're in the exact same place. That is where we are in healthcare today. That's the frustration. In 2004, the National Medical Association launched the Cobb Institute, the W. Montague Cobb Health Institute. This is a picture of Freedman's Hospital, which was my training hospital and medical school. These other accomplishments of the Cobb Institute in its first decade are listed. One of my colleagues, I heard Dr. Winston Price, who's the Chief Information Officer of our Cobb Institute today, was at the time president of the National Medical Association, is on the far right in the top picture. The lower picture shows when we became a 501c3 in 2011, and I sit at the center with the founder, really the founding board chair, Dr. Cato Lorenzen. And this has been quite an experience. The mission of the Cobb Institute, as I mentioned before, is to focus on identifying and developing solutions that will reduce racial and ethnic health disparities and improve the health of all underrepresented minority patients. And social determinants of health really is a playground of health disparities. All of these different parts of our society contribute to the determinants of health. And if any of these are not addressed, there will be disparities in health. So culture, the social environment, it's, you know, where we grow up, where we're born, where we live, where we work, where we age. I realized at the 20th reunion of my high school in Gary, Indiana, Roosevelt High School, that we had an awful lot of people that had passed away. And being there, working, and seeing those stacks of chimneys and seeing that smoke go across the lake, it finally occurred to me that our environment was not healthy and that we were losing people because of environment and carcinogens. And so this continues in many of our communities. As we know, Black communities happen to be in not the most healthy communities, and they've been changed, raided, whatever you'd like to say, by highway systems, railways, whatever there has been. And this all contributes to poor health. So it was COVID that impacted our health in such a way and impacted each of these factors in healthcare disparities. I mean, through social determinants of health, each of the categories, shall I say, that we realized just what terrible shape we were in many, many communities, and how vulnerable our citizens are who live in these communities and don't have these types of security. But access to healthcare is certainly extremely important and is the topic for today, because if we don't replicate our health providers and our scientists, then we will not be able to solve the Rubik's Cube of health disparities. This is interesting. This is the Black-White Index, and this of course reminds you of the what was it, the 5/8 rule or whatever about African Americans, that we weren't 100% people. But in looking at the social determinants, it shows that in many areas, African Americans continue to lag behind the norm or the average. Education, 74.8% of 100%. Social justice, 55.7%. Economics, 65.6%. Interestingly, health is rated at 88.6% now by this particular equity index breakdown. This is the slide that I like the best, because these terms, equality, equity, and justice, that we throw around all the time, we need to have some way of illustrating what they actually mean. And so equality is the assumption that everyone benefits from the same supports. And of course, we know if we have equal blocks to see over the fence, the short guy is not going to see over the fence, even though everybody has equality. So this, in theory, is equal treatment. It's unequal for the short guy. Equity is when everybody gets whatever they need. So we're now focused on health equity rather than uh, health equality, because this is really what affirmative action is. It's producing equity so that everybody has the same chance. If you need a taller stool, if you need more time, if you need resources, whatever is necessary to achieve equity. And then, of course, the social justice and the goal is to not only have equity, but have justice where we all see everything. We all see the entire picture, because there's no longer a wooden fence. There's a metal fence there, wire fence, so we can see the entire field, and we can, no matter what size we are or what our visual acuity might be. So today in the United States, we mentioned that there are approximately 96,000 medical students. Those are really big numbers. 96,000. There are about 989,000 physicians in the United States and its territories. And many of those physicians most of those physicians are in office-based practice. And as far as research is concerned, only 1.2%, medical teaching only 1.2%. And with regard to African Americans, the percentages are even lower than that in most of our specialties. So there's still a great challenge to create the type of career path that's going to make a difference with health disparities or with health equity, with social justice. And so the medical schools have a very tall task to try to make that happen. The current status statistics with regard to the physician's workforce shows that about 24% of active physicians are international medical graduates. And this is all 2022 data. More than 1/3, or 37.6%, of the active physician workforce was female. And so certainly in the next 10 to 20 years, that's going to be 50% or more of the active workforce will be female. 23.2% of active physicians were age 65 or older. So I feel comfortable then that I'm in somewhat of a majority of of old people who haven't figured out how to retire. But I think it's also points to the fact that many people who are over 65 had in mind that they would practice medicine their entire life, or certainly 40, 45 years. Now that's not the case. Many are leaving the practice of medicine early, so that's complicating our needs in terms of replacement of physicians in our community, and that's going to have an effect on health disparities also. And certainly in general, women are not staying in the field of active practice as long as men. So I think these statistics are going to be entirely different in 10 to 12 years. Presently, 5.2% are Black or African American, of all active physicians in the United States. And so the Cobb Institute, in its wisdom, was aware of what was going to happen with the Supreme Court, as were many others, and had prepared a statement to be issued, and it was issued the very day, June 30th, 2023, the very day of the Supreme Court decision or ruling or opinion. And I think the key point that I'd like to make is that, as we say, if the majority ruling was sound, there would be no need to legally overturn affirmative action policies, and certainly no rationale to selectively preserve them in our nation's military academies. As you know, affirmative action has been approved or protected in military academies, but not in general. So health disparities are perhaps our most profound evidence of America's continued need for affirmative action in higher education. So that is really the summary of my talk today. We had a symposium at the Cobb Institute on July 30th, 1 month after the ruling in New Orleans at the National Medical Association. We had renowned speakers such as Dr. Ruth Simmons, consultant of Harvard University, as many of you know. Dr. Simmons was president of Smith College, Brown University, and Texas, Prairie View in Texas, in addition to being a consultant for Harvard. And unfortunately, she was the handpicked consultant to support the African-American president of Harvard, who has left that position because of this same anti movement. And our statement, we believe that diversity and inclusivity are key pillars in addressing the challenges of racial and ethnic disparities in health and healthcare. And that was a statement attributed to me. Through our collaborative efforts and collaboration, we cultivate the next generation of scientific and biomedical leaders who will drive change and create a more equitable healthcare system. Excuse me. So here's Dr. Simmons, wonderful picture. She's a wonderful person, gave a fantastic address. And this is the video of that particular program. And it will be available to any of you who would like to see the symposium. It was a 2-hour symposium from Hopwood to Harvard. So you understand where the Hopwood came from. Affirmative action in the higher education, admissions amidst systemic racism and historical racial inequities in health. And then there were guidelines that were recommended by that symposium, which I don't want to read all of these, but I think it's important to track the percentage of underrepresented minorities at medical schools in consideration of historical state bans and recent SCOTUS decisions. So we're like year by year now looking at all the medical schools and looking at the admission rates. But it's important to implement strategies and best practices for improving recruitment, retention, and advancement of underrepresented racial and ethnic groups into medical training, residencies, fellowships, and tenured academic positions. We need the entire spectrum represented. Some of you may have seen the recent the National Urban League publication, State of Black America, in which they talk about landmark decisions that threaten the Civil Rights Act of 1964. And you can see all of the various parts of the or titles of the Civil Rights Act have been challenged legally. So it's standing on shaky ground right now. And of course, the Students for Fair Admissions be president of Fellows of Harvard College, and the Students for Fair Admissions be University of North Carolina, and attacked on Title VII of the Civil Rights Act. So it all makes perfect sense. The AAMC, the Association of Medical Colleges, oversees all medical schools, and it has acknowledged the ruling on race-conscious admissions. It has worked to pivot to continue and support diversity in medical schools, and their strategic plan summarized here by Dr. David Skorton, who is the president and CEO of AAMC. A healthier future starts here and now. From gaping health disparities to uneven access to care, the challenges ahead are daunting. But amid the novel coronavirus pandemic and growing public outrage over systemic racism, excuse me, a renewed sense of urgency offers an unprecedented opportunity for change. in partnership with medical schools, teaching hospitals, health systems, academic medical societies. The AAMC is poised to lead the charge and the change that will improve the health of people everywhere. So we have to partner and we have to depend on them. The Cobb Institute that I mentioned has 4 important pillars. A lot of what we do now is to facilitate networking with research and to train early career scientists and stimulate their interest in becoming to become physician scientists as well as health providers. Cobb
Dr.
Scholar.
Morgan, you have 5
Yes.
minutes, okay?
Right. So the Cobb Scholars is our very active organization of young people who have completed medical school and are seeking careers. We're working with them. This is from one of our recent meetings at the National Medical Association in New Orleans, where the scholars are showing their abstracts and their scientific work. So the real question is, what can we do at ASALH to address health disparities in our communities? And I list 6 E's here. One is to engage those who do not know us. Us meaning ASALH. 2, enlist young individuals who need us. 3, encourage competition. 4, enhance mentorship. 5, evaluate our strategies and results. And 6, to empower our community. And we will end this by remembering Justice Thurgood Marshall, who said, none of us got where we are solely by pulling ourselves up by our bootstraps. We got here because somebody, a parent, a teacher, an Ivy League crony, or a few nuns bent down and helped us pick up our boots.
Thank you so much, Dr. Morgan. And I did put the link to the Cobb Institute in the chat because there's a wealth of information there. I'm going to remove your spotlight now. And if you
Okay.
will stop sharing your screen, I think we might have a few questions. There's one that came in the chat, and it was whether or not that social determinants chart is available. And is that something on the Cobb Institute site, or is that something else that you have some?
I think it may be on the site, but I can make it available and
Okay.
and certainly make the slides available. You know, you have them, but I can find the reference. I think that comes from our Movement is Life, which is another one of our partner organizations.
And since
But
this
yes,
is
we can make that
recorded,
available.
since this is recorded, if people want to go back when the recording's up, they'll be able to see all of that on those recordings too. Because we had some technical glitches, sometimes we have lots in the chat, other times we don't. If anybody has a question, is there something they'd like to ask Dr. Morgan? Let's start with Mike Waddell.
Yeah, thank you so much for that, Dr. Morgan. It seems like what we need is a way to mitigate against people dropping out of the pipeline prior to medical school. What does that look like? Is it paying students to go through a pre-med program? Is it nurse practitioner training? Is there any way to do that?
Well, actually, the symposium that we have this coming year in New York at the National Medical Association is going to talk about pipeline and pathway programs. And it's going to talk about all the things that need to be done to have success. And most of it is involving working with groups of students in a team fashion and having them all work toward a particular goal, and starting with, you know, as low as 6th grade to generate interest in medicine. But I think each community has to assess the needs based on their schools. Like, you know, through doing mentoring in Sarasota, many of us understand the differences between the schools and the challenges and the offerings and, you know, what students have to do to navigate. And so I think that's something that we need to do because we've experienced higher education. We've had children who have had to go through more recently to analyze what kinds of strategies are going to help. So, you know, not to make it complicated, but as you know, there's students that don't do well on their MedCat test. And there's a group mentoring in medicine in New York that's working to with that particular group, and they get them into a master's degree program, and they literally increase their success rate for admission up to 90% to medical school, and their performance on the MedCat exam, and they're very, very intentional about how they do it. And there are a number of other focused mentoring groups. So I would say that early age is one, and focused mentoring groups that have a community of students, you know, so it's not just like one student, because they learn so much and they're influenced so much by their peers.
Before we take any additional questions, Dr. Morgan, if you have some words you'd like us to hear before we stop the recording, because we're going to take questions after the recording is stopped. So if you'd like a closing statement, this is your chance.
Well, I thank you, and I'm sorry for the technical difficulties, but I'm really pleased that so many people in our community are interested in this topic. And when I was attending our meeting last year, I said I need to share this information with people in Asala, because I think many people can take it and come up with solutions that we can all work towards. So that's really my goal at this point, and I just appreciate the opportunity.
Thank you so much. I'm going to stop the recording, but I do want to remind everyone that our next one is going to be on April 18th. And believe it or not, one of the next speakers is actually on this Zoom right now, but we'll save all of that for you to see later. But I'm stopping the recording.